I'm Alfred Beauvais. I'm the editor of Axel, and with me is Dr. Deepak Bhatt, who is a professor of medicine at Harvard Medical School. We're here at the ESC Congress in September of 2013, and we're going to present today's important clinical trials from Wednesday of the meeting. So, Deepak, tell us about a couple of the trials that you thought were interesting at this meeting.
Sure. Well, the PURE study was presented, and this was an international study, a very large study, examining sodium excretion and the relationship to blood pressure. Now, this has become a controversial area as of late, with differing opinions from different professional societies about how much salt is too much salt. But what I think this study nicely showed was that greater degrees of sodium excretion, or in other words, greater salt intake, essentially, does raise blood pressure by a couple of millimeters per gram, though that's only true at the higher ranges of sodium intake.
I think the important part of this trial also was the ability to convert a single urine sample of sodium into an estimate of daily intake, which is a very convenient tool for a large population study. I mean, trying to do a survey of that many people for sodium intake or do blood levels is pretty tough. I think the conclusion here was that the people that demonstrated high sodium intakes were actually the people in the higher blood pressure group.
That's correct, and I think that's an important point. Really, it was folks that had high blood pressure at baseline and older people that were more susceptible to the blood pressure increases due to dietary salt excess. So that does mean older patients of ours who are taking in a lot of salt and have high blood pressure really need to cut back. On the other hand, it does raise the question whether younger folks who don't have high blood pressure, do they really need to cut back on their salt intake?
Right. It does give some insight, and I think you're right. These are good questions to help generate some newer trials and actually to provide some advice to patients about salt intake. I thought it was interesting
Absolutely.
that they sorted China out as one of the countries that has very, very high salt intakes. Let's talk about taste for a couple minutes.
Sure. Well, the randomized clinical trial TASTE was presented earlier during the week at the European Society of Cardiology, showing no significant difference in 30-day mortality for thrombus aspiration versus no thrombus aspiration in primary PCI. That was interesting. But what was presented secondarily was the value of that approach, using a registry. This was a registry in Sweden, and embedding a randomized clinical trial in it, a fascinating concept, and one, in fact, that the American College of Cardiology is also exploring. And this might be a very efficient, cost-effective way of doing randomized clinical trials. Of course, in the U.S., we do have to think about things like HIPAA and a few other considerations, but potentially a lot of promise, I thought.
Well, it comes from Sweden, where all the patients are in a national health system and all the patients are entered in a registry. They're able to be followed longitudinally because they have identifiers. Some of the things we can't do in the United States at this point, but the point is well taken. Individual randomized trials are very expensive, and if you could have a randomized trial sort of riding on the back of a registry, it would cause tremendous reductions in cost and allow you to do more of these. So I think it does have some impact in the registries that the ACC has. And again, one of the things we're going to need to do is figure out how to do longitudinal follow-up with the HIPAA rules that we have to live by.
Yeah, there are definitely some subtleties to just going ahead and doing it, and certainly this type of registry-based approach to clinical trials could be terrific for examining endpoints like mortality, but other more subtle endpoints, stent thrombosis, I still think adjudication and careful trial design probably is useful for that.
Well, let's talk about Arctic gene for a minute or two, platelet analysis at the bedside.
Right, so the main results from the Arctic trial had previously been presented and published in the New England Journal of Medicine and did not show any value to a platelet function guided strategy of personalizing antiplatelet therapy, a topic that's been extremely popular and controversial. And intuitively, it would seem like personalizing therapy is a good thing to do. That's what we always try to do as doctors. But that main study had shown no benefit to platelet function testing. What this analysis examined was genetic testing for various polymorphisms that affect clopidogrel's metabolism. And as it turned out, knowing the metabolizer status didn't help either in terms of predicting events or predicting response to therapy. So once again, we have a negative finding, but an important finding, and it's concordant with the platelet function test finding. That is, neither approach seems to be particularly useful in terms of actually personalizing therapy in 2013. Now, there might be other approaches, other trials, other devices, but at least right now, a rather sobering message.
Right. Helpful to know that what we're doing is getting to the point where we're getting the proper platelet responses, and doing more subtle analysis isn't helping us. And what about AMADEUS? What are we doing with risk and AFib?
Sure. So that was a trial, but the analysis that was presented here was whether construction of a risk score to try to figure out different risk strata for atrial fibrillation patients, is there a way of refining it beyond what we have? And using a lot of fancy statistics, a risk score was compiled, a composite risk score, and as it turns out, really was no better than what we've got right now, such as CHADS VASC or HAS bled. So I think the message of the investigators was right, that when it comes to risk stratification, sometimes simple is better than more complex.
Yeah, I think the key is do a risk stratification. You know, you have the tools, you have HAS bled, you have CHADS or CHADS VASC. They're easy things to use. You should use them, but trying to get real fancy with multiple risk factors or combining these isn't adding anything better.
That's right. So I think that really is the key message then, risk stratify those atrial fibrillation patients, not only for their thromboembolic risk, but also their bleeding risk using existent scores.
Okay, well, that's a quick summary of the Wednesday trials that we think are important and help in making some practice judgments, so thanks for listening.